Perianaesthetic mortality in dogs and cats, a worldwide multicentric study. Anesthesia is a controlled intoxication of the nervous system. Anesthesia leads to complications and sometimes causes the death of the patient. Advances in anesthesia and monitoring have reduced the risks, but many animals that would not die if they were not anesthetized still pass away. Anesthesia can kill. Albrecht and Blakely published the first study of anesthetic mortality in small animals in 1951. The survey of Professors Kathy Clark and Leslie Hall in 1990 was the first major multicenter study in veterinary anesthesia. Dr. Broadbelt's PhD in 2006 and his following publications between 2006 and 2009 were a game changer in studying anesthetic mortality, another reference we have today. However, almost 15 years have passed since their publications, and much has changed in our specialty. More recent works have given us an idea of the situation in several countries, such as Gill and Redondo in Spain, Itami and collaborators in Japan, Matthews and collaborators in the USA, and recently, Shoup, Worrell and collaborators in the United Kingdom. This study aimed to establish the current anesthetic mortality rate in dogs and cats worldwide and its risk and protective factors. A prospective, multi-center cohort study was conducted with 405 veterinary centers in Spain, Argentina, France, the United Kingdom, the United States, Chile, Portugal, and Australia, among others, between February 2016 and December 2022. Different veterinary centers have collaborated, from primary care veterinary clinics and reference centers to university hospitals. Participants were recruited through dissemination through several anesthesia scientific societies, SEAAV in Spain, AAAVRA in Argentina, SAVECH in Chile, and the AVA in Europe. Emails were sent to the WCVAA list and ECVAA diplomates and residents. In addition, social media were used to spread the project. At last, partial results were presented at several national and international congresses, and attendants were invited to participate. A PDF form was designed, and had to be completed whenever a dog or a cat was anesthetized, regardless of the reason for anesthesia and the anesthetic protocol implemented. The completed forms were automatically emailed to a specific email account. 146 variables were recorded on the formulary, including signalment, history, the reason for anesthesia, details of the anesthetic protocol, management, and drugs used, and whether the patient died during the study period. The data filled in the forms were exported to a spreadsheet using Adobe Acrobat Pro. The instructions to the collaborating centers were to include all anesthetized animals. In this study, anesthesia was considered the hypnotic state that should allow endotracheal intubation, regardless of whether endotracheal intubation was performed. Dogs and cats that received only sedatives or analgesics were excluded. Animals were studied between the administration of anesthetic pre-medication and the first 48 hours after extubation. If the animal died during this time, additional information was requested, such as circumstances of death, anesthetic or surgical complications of the case, treatments used, and necropsy results, if performed. The principal investigator classified deaths into 3 classes: anesthetic death, if death could have been directly or partially attributed to anesthesia; euthanasia, animals euthanized due to the severity of pre-existing injuries; or medical, surgical death, if death was due to surgical causes, resulting from problems during surgery, or medical reasons, because of disease progression. Deaths related to euthanasia and surgery were registered and studied but were excluded from the statistical analysis. Anesthesia-related deaths were included in the statistical analysis and were studied deeply. The phase in which the death occurred was classified as intraoperative if it happened during anesthetic pre-medication, induction, or maintenance of anesthesia, and postoperative if it occurred after recovery in the operating room. From transfer to the hospitalization in the first 48 hours after extubation, statistical analysis included a multivariate logistic regression model for demographic and clinical associations with anesthesia-related death. Statistical analyses were performed using the R programming language and several additional statistical packages. The variables were used to construct a binary logistic regression. If p was less than 0.05, variables were considered significant and remained in the logistic regression equation. Anesthetic-related deaths in dogs. 55,022 anesthesias were recorded in dogs. 855 dogs died. In 378, the death was anesthesia-related. 360 were euthanized, and 117 died due to pre-existing injuries or surgical or medical reasons. The mortality index was 0.69. A dog from 145 died. Of the animals that died of anesthesia-related causes, 91 patients died during induction, 50 during maintenance, 43 during recovery in the operating theatre, 192 during the first 24 hours, and 72 between 24 and 48 hours. In this figure, you can see the linear regression model. To the right of the dotted vertical line are the factors that increase the odds of death. Meanwhile, to the left are the factor which reduces it. The generalized linear model showed increased mortality in pediatric and geriatric patients, obese dogs, higher ASA status, and scheduled or emergency procedures, abdominal, orthopedic, neurosurgical, thoracic procedures, and short anesthesia. A reduction in the likelihood of death was observed when asapromazine or alpha-2 agonists were used as sedatives, pure opioids alone or a combination of pure opioids, partial agonists, or agonist-antagonists plus NSAIDs as analgesics in pre-medication. If sevoflurane was used instead of isoflurane for maintenance and with the use of loco-regional techniques. In our study, the overall anesthetic mortality observed in dogs at 48 hours was 0.69%, much higher than reported in human medicine. However, our results align with those reported in studies by Tami and collaborators, although higher than those written by Broadbelt, Shoup-Worrell, or Matthews. Differences in study design, the population studied, the anesthetic management, the definition of death, and the period reviewed could partly explain these differences. Our study reveals that 81% of deaths occur in the postoperative period, a fact already observed in other studies. These results suggest that special efforts should be made to reduce postoperative mortality to reduce overall mortality. The work of the anesthesiologist does not end when the patient is extubated and referred to hospitalization. However, they should be involved in postoperative care, working with the surgeons, hospital, and the ICU team. Dogs at both extremes of age, pediatric and geriatric, have increased mortality. Pediatric patients are not fully developed and have anatomical and physiological differences compared to adults. They are predisposed to hypothermia and hypoglycemia. Geriatric patients have reduced responsiveness to the aggression of anesthesia. ASA classification was presented as the main prognostic factor. The higher the ASA, the higher the probability of death. It is confirmed that it is worth stabilizing the patient and improving their physical condition, as it could significantly reduce the likelihood of death. Urgent procedures have a higher mortality rate, as Broadbelt and collaborators indicated. Non-urgent but unscheduled operations also have higher mortality than scheduled procedures. Spending time on case preparation is mandatory as it may increase the odds of survival. Abdominal surgeries, patients undergoing orthopedic or neurosurgery, and especially thoracic surgeries, are more likely to die than minor surgeries. These are complex surgeries with extensive surgical aggression. We should pay more attention to their management. The drugs used in the anesthetic protocol seem to influence the likelihood of death. There is no standard protocol for all clinical cases, but we must adapt it to each patient. However, we have observed reduced mortality when sedatives such as asapromazine or alpha-2 agonists are used. Surprisingly, combinations of alpha-2 or asapromazine with benzodiazepines do not appear to have this protective effect. Sedatives reduce hypnotic doses and reduce pre-surgical stress. In addition, alpha-2 agonists have analgesic properties and could contribute to more effective analgesia. The use of sedatives as premedicants should be advised if they are not contraindicated. This study observed lower mortality in patients treated with systemic analgesics, such as pure opioids, or combinations of pure opioids with NSAIDs, partial opioids, agonist-antagonists, plus NSAIDs. These facts were already observed in the study of Gill and Redondo. Another remarkable observation is that local regional anesthesia reduces mortality. This finding could be due to the reduction in hypnotic doses leading to better cardiovascular and respiratory stability during the procedure, the decrease of perioperative stress, as Romano and collaborators saw, or both. Our study demonstrates that systemic analgesics or locoregional techniques reduce mortality. In other words, pain kills. Special care should be taken to prevent, diagnose and treat pain, as it not only improves animal welfare, but may also contribute to reducing the likelihood of death during anesthesia. Anesthetic-related deaths in cats: 14,962 feline anesthesias were studied. 115 cats died, 94 were anesthesia-related, and 21 died from surgery or pre-existing injuries. Another 98 were euthanized due to poor prognosis. The mortality index was 0.63. A cat from 159 died. 6 patients died during induction, 18 in maintenance, 13 during recovery in the operating theater, 41 during the first 24 hours, and 16 between 24 and 48 hours. Increased mortality was observed in cachectic cats, higher ASA status, abdominal, orthopedic, neurosurgical procedures, thoracic surgeries, and ventilated patients. A reduction in the odds of death was observed when using alpha-2 agonists as sedatives or pure opioids alone as analgesics in pre-medication. The overall incidence of anesthesia-related deaths in cats was like that observed in dogs. In the past, mortality in cats has been reported to be higher than in dogs. Cats have anatomical, physiological, and pharmacological differences from dogs and have traditionally been less studied. In recent decades there has been tremendous progress in understanding feline anesthesia, and clinicians have improved anesthetic management in this species. However, as in dogs, the mortality rate is far from that observed in human medicine, and much work remains. Again, most cats die postoperatively. Cats have a high incidence of postoperative complications such as hypothermia, hypertension, hypoxia, and pain. Nutrition of the postoperative cat is a challenge, as anorexia leads to metabolic disorders. Additional efforts should be made to improve postoperative care to reduce feline anesthesia-related deaths. Cachectic cats are likelier to die than cats with an average body condition score. Weight loss is often a symptom of disease in cats. Cats hide their symptoms, and clinicians often decide to anesthetize the cat when the disease progresses. Sometimes the reason for anesthetizing cachectic cats is to put them in a feeding tube. Anesthesia in cachectic cats should be considered high-risk anesthesia. The higher the ASA status, the higher the chance of anesthetic-related death in cats. ASA classification is the primary prognostic variable for predicting anesthetic-related deaths in this species. The mortality index with high ASA status is enormous. In these cases, additional efforts must be made to stabilize the patient and improve their physical status. Some procedures have a higher odds ratio for mortality, like abdominal, orthopedic, neurosurgical, and thoracic surgery. Abdominal surgery includes several techniques, such as gastrointestinal surgery, reproductive surgery in females, from elective ovarian hysterectomy to pyometra and caesarean section, and urogenital surgery. Abdominal surgery involves increased heat loss, which has been reported to increase the likelihood of death, as Redondo showed in 2013. Orthopedic and neurosurgical procedures include cats that have suffered fractures or luxations, often caused by trauma, with higher mortality. Often these cats have other injuries in addition to those reported in the reason for anesthesia, and extra efforts to discover and resolve them. Not surprisingly, thoracic surgeries have the highest odds ratio of death. They are high complexity surgeries, and ventilation is mandatory. We have observed that ventilation in cats increases the risk of death. Ventilation can cause damage to the lungs, and it is a massive challenge for these small-sized patients. Proper equipment and a better knowledge of the physiopathology of intermittent ventilation at positive pressure are mandatory to reduce anesthetic mortality in cats. Using alpha-2 agonists as sedatives reduces the probability of death in cats. In our study, alpha-2 is the pharmacological group most used as sedatives. In the survey of Hall and Clark in 1990, alpha-2 was related to increased death. In this study, the most used alpha-2 was xylazine, a low-specific drug with many secondary effects. More selective drugs, such as medetomidine or dexmedetomidine, are now used. The use of opioid agonists in pre-medication also reduces the probability of death. Painkillers, and these analgesics have been demonstrated that increases the chance of survival. Our study has several limitations. First, this is not a randomized study. Participants were clinicians invited to join the study, and they may have a particular interest in anesthesia. It could induce a selection bias. In addition, we need to quantify the response rate of participating centers. Most centers submitted cases intermittently, although the centers were instructed to record all anesthetics. A system of checking or control still needed to be established. Data quality systems should be installed in future studies to ensure the data's quality. Another limitation is the subjectivity in classifying a death as anesthetic or non-anesthetic. We have found differences between experienced anesthesiologists in the classification of a patient's death, which has given rise to a parallel investigation that can be seen in the posters section. In this study, we have chosen to follow the criteria of the principal investigator, who has been studying anesthetic mortality in cats and dogs for more than 25 years, which induces an authority bias. Determining the cause of death should not be subjective and depend on the decision of a single investigator, but there should be a consensus. We invite you to discuss our poster in the poster section. At last, the sample size in cats is small compared to the dogs, and it could not be enough to demonstrate the anesthetic management and the odds of death in this species. In conclusion, the overall anesthetic mortality rate in dogs and cats was 0.69 and 0.63%, respectively. One dog from 145 and one cat from 159 died in the first 48 hours after anesthesia. Most deaths occurred during the post-operative period. There are risk and protective factors that could help in clinical decision-making. This is the bibliography consulted for this presentation. If any of you need a paper, please email me. I will gladly share it. We would thank the veterinarians and nurses of the collaborating centers for their hard work collecting information, which hopefully will help reduce anesthetic mortality in the future. We would also like to thank the conference organizers for allowing us to present our two oral presentations together. It has been much easier for us, and that facilitates the attendees' understanding.